All right, well, we can go ahead and get started with our second session here. So it is my pleasure to introduce Dr. Boyko, who will be giving this session on essential ethical issues in AI and radiology and inclusion, diversity, equity, and equality. So thank you so much for joining us today, Dr. Boyko.
Well, thank you, Jordan, and good morning, good afternoon to all of our 94 attendees. And I look forward to just sharing with you some thoughts about how to start thinking about ethics in AI. Just as some background, I started my AI journey in 2014 when I decided that AI was going to enter into radiology. I just didn't know in 2014 when or how. So I joined part-time industry. So I practice as a clinical radiologist doing neuroradiology and emergency radiology. And 3 years ago, I went emeritus at University of Southern California in anticipation that I thought the AI journey in radiology would accelerate faster in the federal healthcare system. So I joined the VA Southern Nevada healthcare system to try to advance the application of AI in the care of our US veterans. So as some of you who are radiology residents, as you rotate through your VA experience, it'll be interesting to see whether you start seeing some applications of AI during your rotation. So one of the things that I've learned over time is that ethics, which I didn't know much about, but people have kind of shared with me that maybe ethics should be a broader concept and include concepts of inclusion, diversity, equity, and equality. And we'll just touch on a couple of these in the talks. Luckily, we have a lot of organizations that are assisting us in how to shape and form our thoughts about ethics and AI. So as an example, the American Medical Association has a journal of ethics, and they take this view of a robotic arm with the justice scales in the middle to touch on topics that they think are important in terms of how we apply machine learning and AI in the care of our patients, in terms of confidentiality, data security, patient autonomy, system reliability, informed consent, cultural competency, and representation. We won't touch on data security, but I did want to share with you an interesting article that was presented and published out of Israel, where with the consent of the government, hackers were allowed to come into the hospital in the middle of the night and were able to use generative AI, which is how ChatGPT is set up, is using generative AI. And they were able to generate fake lung nodules. And they were able to access the CT scanner and the PACS system of the hospital, and were able to inject lung nodules into CT scans of patients who had normal CT scans. Now, all of this was, of course, monitored and vetted, but it just shows the importance of how people can use generative AI and do nefarious things. So you and I are all going to be the watchdogs to make sure that we understand how we apply ethical use and applications of AI and make sure that we have systems in place so that the tools that we're going to be using in our patient care are ethically deployed and secured. These are just some of my disclosures. And as I mentioned, many organizations are assisting us in this AI ethics journal. So there was an AI bioethics statement by the American College of Radiology. Organizations such as the American College of Radiology issued guidelines on October 1, 2019. And it was an AI bioethics statement, but it wasn't just a statement from the ACR. Simultaneously on the same day, there was a multi-societal statement, both from the Canadian Association of Radiologists and also the European Society. So we are having different organizations assist us. Next slide. And the European ethics group in radiology also issued simultaneously the same statement. So this was an important point about how we were trying to structure different ethics ideas and concepts back in 2019. Next slide. And so one of the recommendations of the report was for a cross-sector AI code to be established, which could be adopted nationally and internationally. And that's why the Canadian and European. And the goal was to try to identify the common good and benefit of humanity for AI, to assist in operating on principles of intelligibility and fairness, and to try to understand that the data rights and privacy of individuals, families, or communities should not be diminished in this journey, and that all citizens should have the right to be educated to enable them to flourish mentally, emotionally, and economically alongside artificial intelligence. And the autonomous power to hurt, destroy, or deceive human beings should never be vested in artificial intelligence. Next slide. And so these are some of the checklists that came out from that 2019 statement about ideas that we should think about maybe implementing in our practice. So these are available for you all to look at and to consider utilization. Next slide. And so in addition, at RSNA, the Europeans helped develop with us and for us a works in progress about an education curriculum. And this goal was to advance the knowledge about ethics and AI. And so they are defining their concepts of AI ethics training similar to what we do in MRI safety, a level 1, a level 2, and a level 3 performance. So we can actually turn to the European sector of our radiology community for assistance in how to shape our thoughts about AI. Next slide. And in this journey, what they implied is that radiologists should prove their imaging knowledge by trying to create this Venn diagram intercept in ethics on AI education, which would be AI knowledge, which is part of the reason why we're here for this course, and then ethics and IT. So the point is that we as physicians and as radiologists and in the radiology community, we need to incorporate ethicists and the IT people and others in our shaping of this knowledge of how to apply ethics and AI. Next slide. And I wanted to just share this couple slides from the VA NAII Brain Summit that was held in September 2022. And in the screen here, you'll see this little picture of Dr. Abramoff, who's an ophthalmologist from University of Iowa. And what he did was he set up a company that is the first autonomous AI tool being used in clinical medicine. And what he was trying to address was a disparity and inequality of patient accessibility to retinal specialists as it relates to diabetes and retinopathy. And you can see in kind of the brown picture of the US map, the distribution of diabetes in 2013 in the United States. And you can see where there's a preponderance of diabetes diagnosis in the US map. In purple is a map of the distribution of ophthalmologists who could treat these patients with diabetes. And you can see there's a disparity in terms of medical service. The area where diabetes is concentrated the greatest has the least number of ophthalmologists to take care of diabetic retinopathy. So Dr. Abramoff wanted to try to deal with this inequity by applying AI. Next slide. And so what Dr. Abramoff was able to do was he established a company called IDXDR. And in the right-hand side, you can see a retina, what a retina looks like in a patient with diabetes who develops diabetic retinopathy. And then you see what the normal retina is. And he developed this AI tool that had FDA clearance and now actually has a CPT code for reimbursement, where you don't need a physician to run the autonomous system. But a patient will look into the scan. The scan will then use the algorithm that's been developed, trained, as Dr. Perch mentioned, on diabetic retinal scans and non-diabetic retinal scans, and will share a diagnosis of whether a patient has diabetes or not. So this is the first example of a totally autonomous AI tool that's been cleared by the FDA and that has been instituted in our clinical practice. And I share this with you in terms of the goal of AI, which is to deal with a disparity of inequality of patient access to subspecialty care. Next slide. You can also see then that there are different kinds of AI. And this goes to the question of what does the A in AI stand for? Some people use the term autonomous, which is what the IDX diabetic retinopathy tool is. Some will refer to the A in AI as augmentive, and some will refer to the A in AI as assistive. So as you start your AI journey, you'll see that there are these different determinations of how the A in AI is defined. Next slide. In addition, we want to understand about how have these AI algorithms been developed and are they biased? And I wanted to share a good example from the dermatology literature that helps highlight bias. This is a presentation from a talk by a dermatologist from Stanford University at the Amy Center Symposium. And next slide. What the Stanford dermatologist focused in on is that 90% of the papers that have been reporting the use of AI in dermatology do not report the skin tone of patients in their cohort in the data set. And it was noted then by the Stanford dermatologists that either dark skin tone patients were excluded or dark skin tone patients were underrepresented, kind of like this concept of overfitting, underfitting. And so this is an important point because we need to understand that we just can't read the paper, but we need to understand what are some of the potential information that helps us understand whether this algorithm could be applied in our practice where we are located geographically will perform. Next slide. And so here's an example of a paper that was written in Nature, and you'll learn through the course about how convolutional neural networks, these deep learning networks, were applied. And if you notice in the boxes, there are different diseases, squamous cell carcinoma, basal cell carcinoma at the top, nevi, seborrheic keratosis. And you notice these skin lesions, if you notice the background is that in this paper in Nature, all of the lesions are in the background of light skin tone patients. And so this is an article that demonstrated the ability of the convolutional neural network to help define these different pathologic skin lesions in this structured convolutional neural network. Next slide. And then Jordan referred to this. On the left-hand side is the AUC curves, which as Jordan mentioned, one of the way data scientists represent the performance of their AI algorithm is to chart out an AUC curve. And this fits under what has been referred to in terms of the statistics of what's called a confusion matrix. And I can share with you all that I was confused why data scientists call their statistical modeling confusion matrix. And I began to learn that what the data scientists want to understand is whether their AI algorithms that they have designed are confused. And how do they get confused? And then how can the data scientists solve this confusion? So that's apparently how the term confusion matrix entered into this terminology that we're all striving to learn. So you can see on the left-hand side, the AUC curves. And as Jordan pointed out, the greater it goes to the left, the better the performance. So this is how the AI algorithms Stanford noted performed. But Stanford also took and developed their own data set that they referred to as diverse dermatology images, DDI. And they included dark skin tone patients with the same lesions as the light skin tone patients. And if you notice to the right, under the dark skin tones, you notice that the AUC curve shifts to the right. It performed poor. And this is the bias because the algorithms that were being used were designed on light skin tone patients. And then they don't perform as well should the same lesion be entered into the convolutional neural network against a dark skin tone patient. So this is an important piece of bias that we need to be aware of. And I really like this example, even though it's not a radiology example, but it's a visual example of how bias can enter into an AI algorithm development unintentionally. But then when we try to use that algorithm in our practice, it tends to fail or not perform as well. Next slide. Dr. Francisco Lopez Jimenez from the Mayo Clinic gave a nice talk a couple years ago about his view as a cardiologist about bias in medical artificial intelligence. Next slide. And what Francisco mentioned was he thinks of 3 different kinds of biases: statistical, social, and social. The potential reasons for bias under statistical and social is just missing data. Patients may not show up on a follow-up appointment and you use their data in developing an AI algorithm, but the key follow-up appointment and information that can be derived from that just isn't in the medical record. Social is related to underlying disparities in diagnosis, and statistical is the algorithm trained to sample is different from the population of interest. So this is something that we want to be cognizant of and understand how a data scientist or an FDA cleared algorithm how it was developed, how it was trained, and to try to get a sense of how it might train to our unique patient population in the geographical areas that we may deal with. In terms of dealing with statistical, and Jordan already referred to that, Francisco mentioned that one way to deal with that and address that bias is oversampling minority subgroups in the training sample, and then tailor predictions or scores for specific subgroups. So this is an evolution. As we begin to learn that there are these biases, we're going to start evolving how we're going to even make our algorithms more patient-friendly and patient-specific and applicable. And again, up to us to understand the different bias categories that we may see creeping up into our utilization of AI. Next slide. And so from this, we actually can see that we can learn a lot about bias by turning towards the aviation industry. So several AI ethicists dealing with AI ethics in medicine have looked towards the aviation industry to understand how do pilots interact with automation, and as a prediction for us to understand what are some pitfalls we need to avoid as physicians in interacting with automation. And so what we've learned from the airline industry and from studying pilots and their interrelationship with automation, such as the autopilot that pilots use to fly their planes, is that there can be a tendency for humans to favor machine-generated decisions. So we just need to be aware of that and to make sure that we don't allow this tendency to potentially cloud our observation that maybe there's something wrong with the AI and we shouldn't trust it. And Jordan referred to that, this whole concept of trust and trustability. And also, we tend to want to ignore contrary data or conflicting human decisions. So some of these points of studies in the aviation industry deal with the aviation safety reporting system that found that pilots frequently fail to monitor important flight indicators, or they did not disengage the autopilot and automated flight management systems in the cockpit in case of malfunction. The learning concept for us is, if we think that an AI tool may not be performing well, then we need to be given an avenue where we can communicate our concerns so that we can do a QA, and people involved in establishing QA can look and see whether we think there is bias going on, and they should look into it to see if any corrective actions need to be taken. And Jordan referred to this because AI models drift. So even though the FDA sets a model, or an AI vendor sends a model for FDA clearance, and we think that, oh yeah, this model has been cleared by the FDA, its parameters have been set. As the AI tool performs on data sets, it will drift or can drift, and its performance can change. So understanding this AI drift concept is kind of part of AI ethics, because it deals with our ability to be good stewards and oversights related to AI. And this goes back to what Jordan mentioned earlier, that people underestimated the power of AI replacing us as the humans in the physician care model. We actually need physicians and the humans to give oversight to the performance of these models. So we're gaining more and more practical understanding of how these aspects are important. Next slide. So under the point about automation bias, this is a nice slide that shows that our human decision-making is that we will tend to take the path of least resistance. If we see the gate is closed, well, we might just go around the other side of the gate. But this creates complacency. So we want to make sure that our trusting of automation bias doesn't lead to complacency, and that we continue trying in a positive way to understand how performance is and to evaluate and give our own personal feeling of whether we continue to trust the AI tool or whether the AI tool just needs to be adjusted because it may have drifted. So this is a kind of an important thing, is don't let automation bias affect your sense of complacency. You have a very important role in terms of trying to make sure that you recognize should bias be occurring in the application of an AI tool. Next slide. So automation bias deals with issues that leads to lack of monitoring and blind agreement. And there are errors then that can occur: over compliance, over reliance, error of omission, error of commission. These are some of the concepts that people have referred to related to automation bias. Next slide. So one of the best examples and unfortunate examples of automation bias was the issue with the 737 MAX disaster crashes. As you remember, two unfortunate flights, the Lion Air Flight 610 and Ethiopian Airlines Flight 302, 737 MAXs crashed because of the interaction of the pilot with the new MCAS interactive system that Boeing installed in these planes. And so the issue that related to the maneuvering characteristics augmentation system, MCAS, was that it was an automated support flight control, and how it interacted with the humans was not really addressed. And this is what led to the unfortunate disaster of these two plane crashes. Next slide. And what we learned in terms of bias is that the pilots were alerted by the system to make an error in terms of what should be done. And the pilots were not trained to understand that the sensor, the single sensor that was on the plane, was giving incorrect information on what the pilots were supposed to do. So even though the system was alerting the pilot to change where the nose should go in the plane, which is down, they should have recognized this, but they weren't trained to recognize this, and that they needed then to disengage the automated pilot system and do opposite of what the automated system was telling the pilot to do. And so this was what we learned was the unfortunate situation was that this automated system and its interaction with the pilots was not well understood. There, the pilots were not well trained to disengage. And what was interesting was when you read this story was that there was another pilot that made the decision to disengage the automated system and thereby averted a crash. And when he landed, his report was not necessarily apparently taken in a timely fashion. So again, this is an example where automation bias, trusting the AI or the automated system was invoked. Next slide. And so the consequences of the automation bias was on October 15, a federal grand jury indicted the former chief technology pilot at Boeing, alleging that he deliberately deceived safety regulations at the Federal Aviation Administration. Next slide. Dr. Topol did a podcast, next slide, and he talked about a report that was published out of the radiology department at Emory about how they designed an AI tool that could take de-identified data and actually recognize the gender of the patient and also recognize the patient's race. Next slide. So this was an example of how the AI tool can potentially still be able to do something that we never thought it could do. Next slide. And this brought up the fact that part of the reason that there is a gender preference in certain AI algorithms and that it can actually guess appropriately what the gender and race is of patients is because there may be a difference in gender and race data sets in these different institutions based on their geography. Next slide. So my concluding thoughts is that radiologists will remain ultimately responsible for patient care, but we still will need to acquire new skills to do the best for our patients in the new AI ecosystem. The radiology community needs an ethical framework to help steer technological development, influence how different stakeholders respond to using AI actions for and increasing the use of AI with patients. And this represents the core principles upon which this framework can be administered. So thank you for your time and thank you for letting me join this educational opportunity with you.
All right, fantastic, Dr. Boyko. I really appreciate you giving such a great talk. It's great to see the perspective of the ethical issues facing AI, even outside of medicine and other industries as well. So anyone who has any questions they would like to ask, please feel free to just pipe in from the audience or type into the chat. But I would love to make the first question. So with automation bias, what do you feel like is an effective way to combat automation bias?
I think exactly what you are doing and the committee members of Air Education are doing is education. I'm using an AI algorithm in my clinical practice. I was given 10 minutes of training, and after 10 minutes, I was told that I was asking too many questions. So we need to make the AI vendors accountable. If you're going to give us an AI algorithm, you've got to give us the AI education. And I think we need to see the AI vendors investing more and more into educational formats that you're developing. So education, I think, is very, very instrumental in us being able to deal with all these challenges. And we need to have industry provide the resources and invest the resources in AI education.
That's great. Well, I will open it up for questions here as well. I think from the in-person audience. All right. I think we covered it well. Looks like our Q&A is clear as well. So if there are any additional questions, please feel free to put them into the chat. You can email me personally. You can reach out to us on Twitter. I'll send those to you personally, Dr. Boyko. And thank you again for your excellent lecture today and support for the course.